neuroradiologist in Ghent University Hospital in Belgium, and welcome to this presentation on how to read a brain CT. This presentation will cover the basics of analyzing and interpreting a CT of the brain and is mainly aimed at medical students and young radiologists at the start of their career. At the end of this presentation, you should be familiar with what a CT looks like of the brain. You should be familiar with the basic anatomy of the brain and recognize it on a CT image, and you should be able to recognize some of the most common pathological entities on CT, like an ischemic stroke, hydrocephalus, or an intracerebral hemorrhage. What are the topics I'm going to cover? I'm going to start with a brief description of the physical principles of CT. Then we're going to discuss basic brain anatomy, followed by a discussion on the imaging appearance of several pathological entities like an ischemic stroke, an acute cerebral hemorrhage or intracranial hemorrhage, hydrocephalus, brain herniation, and then some other entities I believe every radiologist should be able to recognize on CT. Let's start with the basic principles of CT. What is a CT exactly? Well, this is a CT machine. It's one of the CT machines we have at our hospital. And as you see, there's a table and the patient is positioned on the table, and there's a huge tube here, the so-called gantry. The table moves through the gantry, and while the table moves through the gantry, there's an X-ray tube moving around the patient in the gantry, emitting X-rays. And that is basically how a CT machine works. So this is a nice drawing I made. What are the main components of the CT machine? Well, we have the central table on which the patient is positioned, and in the gantry we have the rotating X-ray tube, but also present in the gantry are a ring of stationary detectors. The X-ray tube emits X-rays, photons, and the energy of these photons is detected by the stationary detectors present in the gantry. Now, the X-ray tube moves continuously in one direction. I was not able to create an animation with the X-rays, but it also means that the X-rays are also continuously rotating, or the X-ray beam, the fan beam, is rotating as well. Now, this happens while the X-ray tube is moving around the patient, emitting X-rays, and at this specific moment, the table is moving through the gantry. So if we were to look at what the transmitted radiation looks like, it will take on the form of a spiral or a helix. This is how the current generation CT machines works, and this allows us to scan a large anatomical area in a single breath hold. It's a way of scanning very quickly, because in the old days, a scan was made slice by slice. This is no longer the case with current generation CT scanners. Now, what interests us the most is the image, but it's good to have an idea on how this image is created. So afterwards, the data is analyzed by the computer, and 2D, two-dimensional image slices of the patient are created. How does that happen? Well, each of these slices can be subdivided in a matrix of 512 on 512 volume elements or voxels. Sometimes it's 2024 and 2024, but never mind that, it's not that important now. And during the CT examination, each of these volume elements, each of these voxels has been traversed by numerous X-ray photons, and these carry a certain energy with them, which can be detected by the detectors located in the ring of the gantry. Now, this is an example of X-rays passing through the slice. So they are transmitted here by the X-ray tube, and let's say a certain number of photons are transmitted, the number X. They go through the air, and well, because they never encounter anything, most of them will reach the detector. So let's say about the same amount of photons reaches the detector on the other side. What happens if X-rays are transmitted that pass through a structure such as the brain? Well, some of these photons will be absorbed in the brain tissue or will be reflected by the brain tissue or by the skull. So the number of photons and the amount of energy reaching the detector on the other side will be lower. It will be the number of photons X minus the number of photons that are absorbed or reflected. Now we have a value of how much photons reach the other side, but that does not allow us to calculate how much photons were, let's say, reflected or absorbed at a certain point in space here. So we only know how many went through it. How does a CT machine work? Well, basically, we do that operation in multiple directions, and at the end of the day, we get a matrix of values, and then we can calculate for each voxel how much X-ray energy, how much X-rays or photons were actually absorbed or reflected, and that's something we call attenuated in a specific voxel. And that's very interesting. So the intensity, as said, has been transmitted or has been measured by the detectors. And from these intensity measurements, the density or the attenuation value of each specific voxel can be calculated. So basically, what the machine does is it doesn't really generate an image, it generates a number of values, and these values reflect how much X-rays or photons were absorbed or reflected in a specific voxel. And that depends on the kind of tissue that is there. And if we then translate these specific values in a grayscale, well, that will allow us to generate an image. So it's basically translating these numerical values in grayscale in an image form, and that is what we look at when we look at a CT image. Let's move on to the next slide. So this is the matrix containing all the values. We can already see or recognize the shape of a head in those, and that is what the CT image would look like. Now, very, very basic. Now we're going to analyze the CT image, but the basics of the CT image. And to put it very simply, structures that are black on a CT image are called low-density structures, and a lot of photons were able to pass through them. So not a lot of energy was absorbed or reflected here. We call those hypodense structures. And then we have structures that are very dense, hyperdense, and these are structures through which photons were not able to pass, or a lot less of them were able to pass through them. So there was a lot of attenuation of the X-ray energy in these specific structures. There is something we use as radiologists, and it's called the Hounsfield scale. So I said that each voxel has been given a certain numerical value, and I don't really know how these values, what these values are measured in, but to make things easy, Godfrey Hounsfield, who invented the CT scan, developed a scale that we call the Hounsfield scale, and he said, let's just give the attenuation value of water the number 0. So that will be the reference point. And let's just give all other attenuation values, relative values, compared to that of water. So that's what we do in the Hounsfield scale. We give water an attenuation value of 0, and then all other attenuation values are compared or calculated in comparison to the Hounsfield unit of water. And then we have structures that are hypodense compared to water, have a lower attenuation value. A typical example is fat. Fat has an average Hounsfield unit of -100. And of course, air has a very low attenuation value because there's basically almost nothing present in air that can reflect or absorb your X-rays. So air has a very low attenuation value of -1000 or even less. Then soft tissues have a density that is somewhat higher than water, 20 to 45 Hounsfield units. Acute blood typically is hyperdense compared to soft tissues and water, and has Hounsfield units of 60 to 90. If we administer iodine-based contrast agents to a patient, These have a high attenuation value of 100 to 500 Hounsfield units, and one of the most hyperdense structures, or the most hyperdense structure in the body, would be the bone. The bone consists of trabecular bone, which has a somewhat lower attenuation value compared to cortical bone, because the bone is less dense there, and there is also, that's the part of the bone that contains the fatty bone marrow. And cortical bone has a very high density of more than 1000 Hounsfield units. Let's translate that information to this CT image. Here we see cerebrospinal fluid. It's very black. It has a density of 0 Hounsfield units. White matter has a higher density, of course, but is still relatively dark, has a density of about 25 Hounsfield units, and it's darker than gray matter. Gray matter is hyperdenser than white matter, with an average density of 35 Hounsfield units. And why is that? Because the gray matter contains a lot more cellular elements, the neurons, compared to white matter. White matter mainly consists of myelinated axons, contains less cells, and there's relatively more water present in white matter, decreasing its density. Then the skull has a very high density of 500 to 1000 Hounsfield units. Then we have a thin layer of subcutaneous fat in the scalp with a density of minus 100 Hounsfield units. And lastly, we have air surrounding the skull. Translate this information to pathology. Very basic, an acute hemorrhage is, as said, hyperdense on CT, and is an example of an acute intracranial hemorrhage. And pathology containing lots of water, let's say cerebral edema in an acute ischemic stroke, will be hypodense because it contains a lot of water, and that will decrease the density. This is a patient with an acute ischemic stroke in the territory of the left middle cerebral artery, and we see that the brain parenchyma here looks swollen and is very dark because it contains a lot of water. It's basically an area of focal cerebral edema. There are some densities that are physiological, and you should not confuse them for pathology, as sometimes happens when a young resident is on call for the very first time and is afraid to miss something. So I have seen this happen in practice. The patients are okay because nothing was wrong with them to begin with. What are typical examples of physiological hyperdensities? Well, we can often see very small calcifications in the lateral ventricles. These are choroid plexus calcifications, and we often see a nodular calcification located along the midline. This is a pineal gland calcification. You will see these very, very, very often. The older patients get, the more likely you will see them, but you can also see them in young patients already. And this is another example. These are calcifications in the globus pallidus of the basal ganglia on both sides. A very frequent finding, especially in the older population, can be a bit confusing if it's unilateral, but it can be unilateral. In this case, it's symmetrical, makes it a bit more easy, but if you just see it on one side, you might be a bit confused or think that this might be a small hemorrhage. If you doubt, do measurements or look at your bone window, but more about bone windows later. And we also see a calcification in the pineal gland and in the choroid plexus on both sides in this same patient. Now, very important when examining a CT is to master the art of windowing. What is windowing exactly? Well, we talked about Hounsfield units. Now, let's say the number of Hounsfield units or CT numbers a computer can recognize is about 2000. It's probably more, but let's say 2000. The human eye, however, because these numbers are translated in a grayscale image. However, the human eye cannot distinguish between 2000 different shades of gray. According to popular literature, 50 shades of gray is probably the maximum. And if we were to create an image of the brain, showing us all Hounsfield units from minus 1000 to plus 1000, so the density of air to the density of cortical bone, this is what that image would look like. So now we can see all Hounsfield units from very, very low to very, very high. And what do we see? Black air, a very dense, very hyperdense skull, and everything in between looks grayish. So it's impossible to recognize the structures of the brain. We cannot tell the difference between gray matter and white matter. We can barely discern the ventricles. We can see them a bit, but not as clear as we would like. So this kind of image is definitely insufficient for diagnostic purposes. So how do we solve that? Well, quite simply, we just don't visualize all CT numbers or all Hounsfield units. No, we use a window. That's what windowing is. We only display a limited number of Hounsfield unit values, and well, you have a lot of possible windows. We choose those values in such a way that it shows us the structures we're interested in the best. So the values we use for looking at the lungs, for instance, are different from the values we look for looking at the bones or looking at the brain parenchyma. I'm just talking about neuroradiology, so we're going to talk about some windows in neuroradiology. What are some concepts you should know when talking about windowing? Well, this is a window, of course, and everything that lays outside of that window will be black if the values are lower than the values in the window, and all values that are higher than the values in the window will be white. Okay, that's for starters. Then the window width is something you should know. That's basically the range of Hounsfield units that will be displayed in shades of gray. And then we have the window level or the window center, which is the central number or the middle number of all the Hounsfield units in the window width. Okay, let's apply this a bit. I'm showing you images of a brain window and a bony window, and that's what you typically get when you do a CT of the brain. Automatically, the computer sends you images in brain window and bony window. The brain window images have a high soft tissue contrast. If you look at the skull, it's just uniformly very dense, but we can clearly see all structures of the brain. We can make a difference or see the difference between white matter and gray matter. We see the deep gray nuclei, we see the ventricles, so that's a good window to look at the brain parenchyma. And then on the bone window, everything looks gray except the bone, but we can see the different components of the bone. We can see the outer layer, the inner layer, we can see the diploe containing trabeculated bone or trabecular bone rather. So this is a very good window to look for bony pathology like fractures, and it has a high bony contrast. I do not know all these values by head, but it's just an example. So for a brain window, we have a window center of 40 Hounsfield units, which is about the density of gray matter, and we have a relatively narrow window width because we only want to see soft tissue structures. In a bony window, we have, of course, a window center that's quite high and a very large window width because we mainly want to see contrast in the bony structures. You have to use both windows self-evidently. This is a patient with an intracranial hemorrhage. It's an epidural hemorrhage, and we know that these are often associated with skull fractures. However, it's impossible to recognize the skull fracture on the brain window setting of this CT scan. We have to look at the bony window, and then suddenly we see this small fracture line in the right frontal bone. Another window that you should use, but is not automatically generated, you have to create it yourself by using your mouse and windowing the image, as the so-called stroke window. And what's a stroke window? Well, it's basically windowing your image in such a way that you generate a lot of contrast between gray and white matter. And why would you do that? Because signs of early ischemic infarction can be very, very subtle. If you create a lot of contrast between gray and white matter, you can more easily pick them up. This is a brain window, and at the first glance you'd say, this looks okay to me, nothing out of the ordinary. But if there's a suspicion of ischemic stroke, window the image very, very hard. This is a typical stroke window. So the level is about the density of gray matter, 32 Hounsfield units in this case, can be 40. This is not absolute. Yeah, I never look at these values. I just create an image that looks a bit like that without really looking at what's my window width here. But it's just an example. The window width is very narrow, 8 Hounsfield-Units, because we want to have a lot of contrast between structures with similar densities. And if we now look at the image we created this way, the stroke window, we see that the brain parenchyma over here and the left parieto-temporal transition area looks relatively hypodense, and we cannot see the difference between gray matter and white matter. This is an early ischemic stroke. This is early edema in infarcted brain parenchyma. And if we now were to look back, oh yeah, let's first compare it with the normal side, where we clearly see a normal differentiation between gray and white matter. And if we now were to look back at our brain window image, yeah, you might already see it, but it will be, well, if you're a bit experienced, you probably pick it up, but if you're not experienced yet, definitely use the stroke window, and even experienced radiologists use your stroke window to pick up these very subtle signs of early ischemic stroke with subtle obscuration of gray-white matter differentiation and hypodensity of the infarcted brain parenchyma. Use the stroke window. Another window that's important for neuroradiologists is the so-called subdural window. This is a patient who suffered a trauma. If you look carefully in the soft tissues of the scalp, you see some swelling here and the subgaleal tissues. This is a small subgaleal hematoma. And now let's look if we see an intracranial hemorrhage over here. Maybe you've seen it, but maybe you don't. But everyone will agree that the image or the pathology is a lot more clear on this subdural window. Now, what did we do here? We see here a small left hemispheric subdural hematoma. You can also see it here, but notice that there is very little contrast between the skull and the subdural hematoma. The lack of contrast between these structures can make a subdural hematoma, if it's very small, sometimes very difficult to detect. By using a subdural window, we actually create a lot of contrast between the hematoma and the overlying skull. And what do? We use a relatively wide window width of 100 to 300 Hounsfield-Units and a relatively high window center. So blood has a density of 60 to 90, so that should be about the center of your window when looking for a small subdural hematoma immediately underneath the skull. So let's summarize these windows. The brain window is the classical window. That's what you start with. But if you're dealing with a stroke patient, use the stroke window. Use a window center that's about the density of gray matter with a very narrow window width. And in a subdural window, use a window center that's about the density of acute blood and use a relatively wide window width to make or generate more contrast between the skull and a small subdural hematoma. Now, a final word, and also very important, is recognizing artifacts. Artifacts are very frequent, and what do we talk about when talking about artifacts in radiology? It's basically something you see on an image, but that is not real. It's not present in the patient. It's created by the software or by an error during the making of the scan. So it's basically a false image. And it's important to be able to recognize artifacts because you should not confuse them for pathology. And these are some of the most frequent. We see here that the brain looks very blurry and also the skull. Is this a fracture over here or not? Well, very difficult to tell what happened here. The patient moved during the scan, and motion artifacts are a very frequent cause of artifacts during CT, and of course, they make interpretation difficult. The main thing is, don't call this a fracture, but on the other side, it's also difficult to with certainty rule out a fracture in a situation like this. The images are very blurry and very unsharp. Another frequent artifact is the following. Do you see all these black lines located in the cerebellum and the brainstem? This is also a very frequent artifact. These are generated by these densities over here. Oh, and there should be one on the other side as well. The patient had earrings. earrings are very, very dense structures. They basically reflect a lot of the X-ray photons, and only photons with very high energies go through them. We call those beam hardening artifacts because as only photons with high energies move through them, the beam is hardened. So a lot of energy, a relative high amount of energy, is received by the detector on the other end, and this creates these hypodense or black lines in the image. They can be seen located between two dense structures, and this is a nice example because the patient had two earrings, and notice how these lines really go from one earring to the other. But we can also see them between bony structures, which are also very dense. For instance, a typical location would be the brainstem because we have the temporal bone on both sides, and we see that there is a lot of streaking going on over the brainstem, but also in the temporal lobes, which are often also very susceptible to streaking artifacts or beam hardening artifacts. Here's another example. This looks hypodense on the axial image. You might confuse it for pathology, but if you compare it with the coronal image, we see that there is a lot of beam hardening going on between the very dense bone between the very dense temporal bone on both sides. Typical location for beam hardening artifacts, the brainstem, sometimes making the detection of a small brainstem infarction very difficult. The origin of these beam hardening artifacts is unclear to me. They might have been created by something located outside of the patient, but we see it's once again a nice example, these black lines coursing through the image, distorting the image. And you don't necessarily have to have two dense structures. Here we see a lot of black lines radiating from this central structure, and this was a coiled aneurysm. So solitary structures that are very, very dense can also create beam hardening artifacts. A final artifact you should definitely know are partial volume artifacts. This is an example of a patient who had this slightly hypodense structure located in what looks like the transition area of the right parietal and temporal lobes. But luckily, CT images are now automatically generated in multiple directions, or we get multiplanar reconstructions in the axial, coronal, and sagittal plane, and we can correlate this hypodensity with another plane, and we see that this was actually the Sylvian fissure. This is what we call a partial volume artifact, which means that the density or the attenuation value given to this voxel is basically an average of all structures in that voxel. So it's a bit of cerebrospinal fluid located in the Sylvian fissure, making it a bit more dark, but not as dark as fluid because it also contains a little bit of cortex. Let's summarize what are our main artifacts and do not confuse them for pathology. This brain looks very blurry, but do not call this diffuse brain edema. If it's present, it's impossible to say at the moment because the brain is so blurry because the patient moved during the scan. This also makes the detection of skull fractures or very small hemorrhages located underneath the skull very difficult. This patient had beam hardening artifacts, which are often present in the posterior fossa because it's a small space completely enclosed by bone, so very susceptible to the creation of beam hardening. And how do you recognize them? As dark streaks behind or between objects or structures of high density. And finally, a partial volume artifact, which is an artifact created by averaging the attenuation of different tissue densities in the same voxel. But this can easily be solved by looking at your other imaging planes. This concludes the introduction on the physics of CT and basic interpretation of brain CT. We have introduced the concepts of windowing, extremely important, and we now know how to recognize some artifacts that we should not mistake for pathology. For the second part, I'm going to talk about basic brain anatomy on CT. It will be extremely basic, but the structures I will talk about are the ones every radiologist should be able to recognize.